Way to PACES, the right way.
Right, welcome to Way to Paces, one of the free sessions. Today it's about approach to clinical error, station 4, communication skills. And the scenario we are going to discuss today is 76-year-old Anthony Brook was admitted to hospital with the back pain and fever. Investigations revealed pyelonephritis and he was treated with gentamicin. The drug level had been checked, but the on-call team missed that information and unfortunately had given gentamicin. That means the drug level was too high when it was checked. Anthony started to recover from pyelonephritis, but he had the tinnitus in his right ear. Discuss with him about the medical error and answer his concerns. See, this station, how to approach is the thing people asked me so many times before, because people who are going in the paces or with the various levels of journey. So one might be just finished MRCP part 2 written and waiting for the paces and know the system and things over there. The other one who had a few study partners and practiced a few and just moving on to the journey. Yes, some people will be waiting to go for the exam just in 2 weeks, 4 weeks, or even few days. So with this in mind, because we were doing lots of role plays, if you go and have a look at the free videos in like a YouTube channel as well as in the website with the link to the YouTube channel. And when I say website, it's www.waytopaces.com. Go to the videos and lots of free videos are there. So most of them were role plays and some more presentations. So what feedback I got from candidates who are appearing for PACE exam is, yes, we are doing the role play, but we need to know more about the principles and procedure and what are the things we need to consider before going into the station. So I agree, this might be very useful for people who are in the starting stage, but I guess it will also be useful for people in the middle and near the end as well. The reason I'm telling this is, let's say, for example, we started practicing with the role play and practicing with the study partners this scenario. Immediately we will start discussing, and then at the end we'll finish with the kind of feedback, and then we'll complete the scenario. But if we do the same scenario again without the base structure, without what we are going to ask, and then how to frame the interview structure, it's very difficult to change. And we'll be doing the same thing again and again unless we know the basics. I think that's where candidates are coming from, and I would support that. So mere practicing alone won't be helpful. We need to know about the structure, framework, and then what to do, how to do. Then only we can step up our communication skills and then improve as the day goes on. So this session is about approach to clinical error, and then what are the things we need to consider, how we are going to communicate in station 4. First of all, clinical error. It's a theme, one of the themes, I would say. So there are lots of themes there: breaking bad news, confidentiality, explaining a procedure, explaining about like a discharge plan or process, and then lots of issues there. So this is one of the theme. And when you get the theme, see, let's say the scenario, if you read the scenario, within 5 minutes of the preparation time before you go to the station, there are a few things we need to think about it. First of all, what theme it is under. And then the next thing is, what are the questions we need to ask, or what are the information we need to tell. And the third thing is, what are the questions patient or surrogate or the family might ask us, and how we are going to answer those questions. And the last one, definitely, what are the questions or what are the possible questions from the examiner and how we are going to answer those. So this is the framework we need to have before we enter any station, particularly in this scenario, it's a station 4. So communication skills is a two-way, doctor and the patient. So first part is what we need to tell the patient or the surrogate here. Second part is what we need to get information from the patient or the surrogate. And the third part is how we are going to manage the questions or answer the questions from examiner in a most appropriate and correct way. I just told you the theme is medical error. So the other theme is like it's a subset of a kind of a breaking bad news, I would say. So even though it's a medical error, so we are going to tell something bad which happened to the patient or the surrogate, and then that's a kind of a breaking bad news structure will come into play here. So that's what the theme under. And the main difference between purely breaking bad news and then breaking bad news plus medication error is, say it's like a double whammy here. See, breaking bad news is you do some test and the test result has come back, let's say CT scans come back as a cancer or the biopsy results come back of cancer, and then we can say no reversible causes have been found, it's the end of life. So those kind of things are like a breaking bad news, but it's pertaining to the results what we get from people or patients. So in those cases, unfortunately, we tell them what's going on, but we were not involved in the process because it's the natural progression of the illness. Yes, it is a bad news, but it's due to the natural progression of the illness. But in this case, it's not like that. Something happened, and that should not have been happened, but that something happened because of us. When I say us, is the healthcare professional or the system or as a whole. So in that case, it's a double whammy. We are going to tell the bad news, and we are responsible and accountable for that bad news to the patient or the surrogate. So we need to be mindful of those principles before we get into that. So this is the first one. And the same rule apply in breaking bad news here as well. Like a warning shot and then like apology and then need to next immediate thing is like emotions. So we need to be ready for the emotions coming from the surrogate. So if you're going and giving like a CT scan, you expect a cancer, but nothing was there. It's a happy, jolly news. So no need to worry about it. You say, and then they will say, I'm glad to say that CT scan didn't show cancer. That's a good news. Fine. We'll be happy. Patients will be happy. And then good closure out of the consultation. But in each and every bad news, the emotions are not that pleasant. And we all know that. If it happens to one of us as well, we'll be in the same situation. So we know that the emotions we can expect are, first of all, definitely will be angry. Patients or surrogate will be angry because they shouldn't have got that. They got that problem due to us or the medical error. The second thing is worry or the concerns. See, that itself is a anxiety. So those things can come up. So we need to see how things go with all the emotions and then get prepared for the scenario. Right. Anybody wants to do a quick role play in this scenario, keeping everything in mind? Are you on the video, Dr. Bilal?
Yes, sir. Hello, sir. How are you?
Hello. Yeah, I'm fine. Thank you. So have you read the scenario?
Yes, sir.
Okay. And I'm sure you would have considered whatever I've told just now.
Yes, sir.
Timing as well. It's a 12 minutes and then a warning, then 2 more minutes. You have
Okay, sir.
and then 1 minute to collect your thoughts and 5 minutes with the examiner. Okay?
Yes, sir.
Right. Okay, right. And Dr. Ganesh is also on the line. Hello.
Yes.
Right. Shall we start?
Yes, sir.
Yeah.
Okay. Sir, should I start?
Yeah, start.
Okay. Good evening. My name is Dr. Bilal,
Mm-hmm.
and I'm one of the doctor here in this hospital.
Yep.
I have read your case notes, but isn't it better if you can tell me in your own words how may I can help you?
Oh, it's I don't know. If you have done the case notes, you know exactly what's happening. See, I came with the back pain and then a temperature. So they said I have some kidney infections. So they gave me some antibiotics, and then I think I'm getting better from back pain and no temperature, and back pain is settling. But I don't know. I got some ringing in my ears. So it's all the time there. I know you are very busy in your schedule and then you need to look after all the patients. So I come with the one problem and you try to correct it and I get another problem. So I don't know. How can you help me with the ringing of ears? So I want to discuss with you about the ringing in my ears and then what to do. And then like you treated my kidney infection, I have a great confidence in you that you will treat this as well.
Well, Mr. Anthony, I can understand your concern, and it has been very stressful for you to have a ringing sensation in your
Yeah.
ear.
Yeah.
Let me explain that you have got a very serious infection in your kidney, and the infection in your kidney was very serious, and sometime if it is not treated appropriately, it may lead to certain grave complication like kidney failure or uh, so we as a team try to cure you and solve the problem of infection by giving an antibiotic, what we call as gentamicin. So gentamicin did very well and it cured your kidney infection. But unfortunately, I have something, uh, I have to tell you something bad. So would you mind if I can tell you?
What, you have to tell something bad? What do you
Yes.
mean by you have to tell something bad? I thought everything is good, isn't it? So as you rightly said, it's a severe infection, and then it's got serious complications. So you pick the right medications and given to me, and I'm improving. So it's all going in the right way. And suddenly, what's bad about it? What's bad about it?
Well, yes. Uh, let me explain that the drug used to treat the kidney infection, although it's very good in treating the kidney infection, but has the side effect of ringing sensation in the ear. So, unfortunately, I'm very sorry to tell you that you have got the side effect because of the medicine used to treat your kidney infection. Have I made myself clear to you?
Oh yeah. Uh, what to do, isn't it? If it's due to the medications and if it's due to the side effects. But
Hmm.
the one thing is, people didn't tell me that I'm going to have this. They didn't. Nobody told me about anything about medication. They said, okay, give you medications, and then that's all. Nobody
Hmm.
instructed me to say that I'll be getting. It's not like if they say I would have changed my mind to say I don't want to have this medication, but it's always a good practice to tell people, isn't it? So now you're telling it's already happened, and now you're telling it's a side effect of the medications. But I'm the one who was suffering. It's not you. And
Yes.
so, I don't know. So what's going to happen with the ringing of ears? So is it going to be forever, or is there a cure, or what you're going to do?
Well, Mr. Anthony, so you have asked a very valid question. So, let me explain that your health was our top priority. So, instead of delaying and just trying some other antibiotic which have less efficacy against the kidney infection, so we tried to treat your kidney infection with a potent antibiotic, so you do not have got any kidney infection, any complication related to the kidney infection. So that's why we give this medicine, so that your kidney get well.
That's okay, because that's okay. I think you're telling the same thing again, because you choose the right medication. You're given to me. It's all done, improving. Everything is fine. But now tell me what you're going to do about the ringing in my ears.
Yes, I can understand that you have a very bad ringing sensation. So let me explain that with the discontinuation of the gentamicin, and some of the people their ringing sensation come to end, and they do not have any permanent side effect. But chances of having these ringing sensation in the ear permanently are very low.
Okay.
So, do you have any other question?
Oh no, because you said it can be permanent, that will not be permanent. If permanent is very low, that's okay. We'll see how things go. So, any medications for this ringing of ears? Can you give anything to reduce it
Hmm.
or stop
Yes,
it?
yes, we do not have any antibiotic, any drugs to stop these ringing sensation in the ear. But just we can do is to stop the drug which is causing the ringing sensation in your ear. And so when your kidney infection get cured, we will stop the gentamicin, and by stopping the gentamicin, the ringing sensation in your ear will be reduced over some time.
So, are you telling me am I still having it?
Yes, you are. We are giving this drug to treat your kidney infection.
No, no. Am I still having it in spite of you knowing that I've got a ringing of ears? Why do I have it then?
Mm, uh, I don't worry, Mr. Anthony. So now I stop this medicine, and as your kidney infection is much better now, so we can switch to some other antibiotic which do not have any serious side effect like that.
Okay, right. Okay, is that all then? So that's fine. Because I don't know when what I'm. So do you need any checkups? Any special checkups for this? I don't know. Well, I don't know what to talk, isn't it? So I come with the problem. You told that's a problem due to the side effect of the medications, and you said medication stopped. And I'm going to have this for some time. I don't know what, who, and so which specialty you don't know the answer by the look of it. So that's all. Then I will stop the conversation. Then is that all?
No, I would like to refer you to some ENT specialist,
Okay.
and he can check your ears, and he may advise some medication or some management option which may help reduce the ringing sensation in your ear. Is that clear?
Yeah. Okay. That's okay. Thank you, doctor.
Uh, Thank you.
Right. I'll stop the clock, and then you had 9 minutes actually. But did you realize what is this scenario about?
Sir, it was the side effect of gentamicin.
Is it a side effect?
Yes, sir. Tinnitus. Sir, it was actually about medical error
Okay.
that the drug level has been checked but is missed.
Okay.
And I think I should have tell this to you as well.
Not as well. That's the main thing here, actually, because you didn't touch at all. So what you said was, we are given gentamicin, side effect of ringing of ears. Okay, then go. So it's unfortunately you didn't go to the main theme at all. So I'm so sorry to say you won't get any marks for this section because you have not touched the medical error at all. So I would say read the scenario clearly, and before coming today, the posters or flyers said medical error, and then the last line said medical error. It's clearly said the levels has been checked but been missed. So in spite of that, I don't know what happened to you today. So you didn't go there at all. It looks like, unfortunately, you designed your own scenario and then started to. So I was waiting for nearly 9 minutes. So I was waiting for the error. You didn't tell me at all. So that's where the tricky thing is. So how do you say the error, and then how do you? What are the things you tell? in this situation? Let's say it's a medical error. What are the things you will tell?
Okay, so let me explain that the drug level has been checked in your blood, but unfortunately we missed that and administered gentamicin to treat the kidney infection. So and there, I don't know how to explain this to patient.
So what will the patient ask?
So patient will clearly ask that why you missed that if the drug level has been checked and you missed that level and then administer gentamicin.
Okay. So what's the answer?
So what can I say? I would like to say that I am sorry that I missed, and I will apologize for missing this.
Okay.
That's all.
How do you go about? Let's say the error has happened. We missed
Yes.
something. So what do you do next?
Yes. I'm sorry, sir. Just to apologize the patient.
Is that enough? So let's say you
Yes.
tell the patient, error has happened. I'm so sorry it has happened. That's it. Okay, bye. Is that okay?
No, sir.
So what else you need to ask?
Sir, uh, I would like to tell that I can stop the gentamicin drug
That again,
and
that you should have done first because your consultation, you started telling like that's a big task you're going to tell. Okay, you're still continuing. I'm going to stop, and unfortunately, that would have been come the first news to the patient. So you say antibiotic caused some problem, and even if it is a side effect, you have to stop. Yeah. Okay. Anything else?
no, sir. I don't know, sir.
Right. Okay. So anyone knows the structure to follow in medical errors? Anybody can tell?
Yeah, I'll try.
Yeah. Okay.
Sorry, I missed in between because I lost the connection. I didn't know how the consultation went. Is
That's
it
okay. Don't
completed?
worry about it. So let's say you
Okay.
read the scenario. You read the scenario, and what are the
Yeah.
things you will consider in this scenario?
Uh,
If you don't mind, you can
first
show
of
the video because only voice it's not going to help for the people.
okay.
Yeah.
Okay.
Yeah.
Yeah. First of all, introduction is important.
Yep.
Like any other scenario, introducing yourself, confirming the patient, and then we have to check the background knowledge, the idea the patient is having about the patient or the relative is having about what's been going on so far.
Yeah.
And sensitively, we have to bring their idea towards the truth, and 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 then we have to tell them that the error has happened.
Yep.
Actually, the treatment has to be that way, but unfortunately, we have done the mistake. We have to admit it, and I think we have to then the patient or relative will get angry, and at that point of time, I think we have to be neutral, not responding every question that the patient asks, and then try to yeah.
What do you mean?
Then
When you say not responding what or every question the patient asks, what do you mean by that?
no. When the patient is in angry tone, the patient will. I think they tend to ask questions, multiple questions. Like, why did this happen? And why is your hospital not responsible for this? No, I think we shouldn't try to answer every question. We have to pause a little bit, and when he is a bit relaxed, then we have to explain why this happened, and then I think we have to apologize. Apology is very important here, and then we have to ask for filing the incident report to the root cause analysis team. And we have to explain that writing this incident report is not for punishing the mistakes whoever has done it, but this is just this is for the staff to familiarize themselves what mistake we have done and how to prevent it in the future. And if patient like to put a complaint, then I think we have to guide them. Despite explanation, if patient or surrogate wants to complain, then we have to guide them to pulse, and then I think we have to answer their questions and any concerns they have. And finally, we have to end the consultation by apologizing again and explaining her that the hospital will be with the patient and the relatives, and we will be providing as much help as possible.
Yeah, that's good. So only one thing to comment or add is, because you mentioned about whenever we discuss about filing an incident report, we need to tell them in terms of this, the aim is not to punish. I don't think we need to go there, the explanation. So I can simply say, we will get it across with our team. So there is a team who look for like an incident whenever when error or incident happens, we need to analyze and then come to a conclusion why it happened, so that we get a proper feedback, and we need to avoid those things in future. So that's it. So don't try to focus personally here. It's not about the persons, it's about the whole system. But we can say that. I'm not saying you're wrong. The aim is not to punish anyone. The aim is to improve better care and the safety and things. But I don't think you don't need to tell explicitly to the patient when we are discussing, because they are the affected people. If you tell them initially the aim is not to punish, means they'll think like we are trying to cover something. So that everything else is perfect, fantastic. But that one sentence, try to avoid when we talk to the patient. So no need to tell them that we are not going to punish the people or anything like that, because if it's not there, no need to worry about it. But you can discuss with the examiner. If the examiner asks something, what will be the aim? What do you do in terms of any feedback for the people or anything? Then you can tell. So in terms of a system error or human error or the individual error, how do you differentiate? And have you got any examples of the system error and individual error?
Individual error, something like a nurse giving a wrong medication, or doctor.
Maybe a nurse, maybe a doctor as well. Yeah.
Yeah, so something like that. Individual error,
Okay.
or doctor writing a wrong prescription.
Yeah, it's good.
Yeah, and system error is the error because of the guideline or the law of the hospital.
Okay. Any examples?
Can't think of one. Maybe something like a hospital authority has decided to keep the guard inside the hospital, and while examining the female patient, it's uncomfortable for the patient or something like that. Because of the system or the law of the hospital, it has resulted in psychological or physical harm to the patient.
Okay, right. So this is slightly different. I'll explain in a different way. See, when talking about errors or the medical errors which can happen, say it's the other way. The system is not enough to check the individual errors. The system, we need to create a system so that it's a safe and it can check all the errors. So when the system check is not in place, and that's what we call the system error, and then we need to do something with the system. And when only individual is making those mistakes, then that's an individual. The system is in place, but still individual is making mistakes, means that's an individual error. See, let's say I can give an example. Let's say checking allergy from a patient. You go and check allergy, it's a part of the assessment. Let's say patient is a penicillin allergy. We missed that information, and then we prescribed amoxicillin, and it had been prescribed and that been given by the nurse to the patient, and then patient developed rash or something like that. It's not a major anaphylaxis, but still a rash and untoward effects that happen. So this is an error happen. So with regard to the system, how do we change the system? See, for example, let's say the nurses can say clearly, they look at the drug chart, and when the allergy box is not completed, they shouldn't give any medications. So they will straight away come to the doctor or straight away go to the patient and check, do you have any allergies? And then make the doctor's document in that one. So this is a kind of system, making a system work so that each and every individual patient's allergy status will be checked unless otherwise, because people won't administer any medications if that box is not completed. If that's important one is there, that box is not completed and people won't give. That's a system. The hospital or our trust or our department create a system to avoid or minimize errors. Even then people can miss. So after saying that, people can miss, that's an individual error. Let's say there is a system to say that the nurses shouldn't administer any drugs if the drug card didn't say allergy status. But still, some of the nurses, so I'm saying nurses, not to differentiate nurses and doctors as well, I'll give you doctor example as well, can administer the medication without doing that. And they may say, one thing is, I'm quite new, I didn't know, I need to check all these things. That's the first answer. And then the other thing, it's extremely busy shift, so I didn't check. So if they don't know, you need to educate them. And again, that is a system responsibility. You need to educate them. If there is a problem with an individual doctor or a nurse, then the answer is you need to teach them, educate them, and take responsibility to cover everyone, including the new joining people to the trust. So if it is, you educated everyone is okay. But is there any way you can, rather than telling individually, is there any way you can prevent by creating any system? That's a system change. And these are the things will come up in the risk management meeting, and the outcome will be like that. So these are the things will come with their outcome. So let's say, I'll give another example. Let's say opioid conversions. Opioid conversion is always tricky. Instead of divided by 2, you can double, and then you can do like a maximum doses. So instead of giving 10 milligrams, you can give 20 milligrams easily with the opioid conversions. So the system will be in place to say that whenever any medication drug chart written in opioid with the dreadful ones, let's say when I say dreadful, it's not about the medication, those medications which carry high risk in terms of errors. For example, fentanyl patch and then alfentanil, those are like very strong and powerful ones. So if you make a little mistake, the untoward effects is more. So in those cases, the system will say, any doctor who is converting some big doses or bigger medications, you have to discuss with another prescriber, it will say. So in that case, let's say I'm doing a conversion. So I need to know that that's individual responsibility, and the organization need to tell them to know about this rule or the guideline. And then next I will come to you. If you are a colleague to me, I'll come to you and say, see, I've done this conversion from here to here. Can you check on your own and let me know whether I've done it right or wrong? Then you check on your own. You come up with a figure, let's say 100 micrograms of fentanyl. Then I come up with the same figure. Then we are right. It's a double checking. And again, in terms of giving opioids in the wards, the nurses, always they have 2 nurses. So one nurse won't go and give it. So one will check everything. What is the dose? Is it 2 milligrams? They put an injection, and the proper vial they are taking, how much they are giving. So one nurse will do it, the other nurse will check it, and the one nurse will document. Then they go in 2s to the patient side. They check the patient identity with the wristband and everything. Then only they give. So this is a system. So there is a system so that to avoid medical errors or minimize medical errors. And when come to individual, the individual need to follow the system. So first of all, create a system as safe as possible, and then educate the staff to know about the system. That will be the induction. So induction, no nurses will say, if you don't tell them, they don't know. That's our responsibility as an organization or the lead or the team in your department. they will take care of. These are all the policies and principles we have. We need to follow this and that. So that is where either these will all come in the risk management team, and then the incident analyzing team will come all those. They will look into detail. Okay, this has happened. Why this has happened? The gentamicin level has been checked, but the particular doctor missed to check the results. So why is it not, has that not been told to that doctor about checking? See, then comes the handover will come. So has that been handed over to him? Because it's a prime scenario. You're not going to face gentamicin each and every patient. So it's an important thing. So then you have to see in terms of the previous team, as they handed over to this person or this doctor, you need to check the gentamicin level. Let's say it's been handed over, then it's purely individual mistake. Then you have to educate the individual to say handover is very important. Every duty you come and check the handover and be vigilant about all these things. If the person says, I know nothing about gentamicin, I've just prescribed me, then there's a total lack of knowledge there. Then you need to educate in terms of what is gentamicin levels and things. So this is where I'm talking about in terms of whether it's a system needs changes or the individual need changes in terms of education. So that's what the whole clinical error is about. Where do we go from here? That's what we do. And we can explain all these things in a nutshell to the patient. So the patient will ask, what is the incident report? You said report, what will happen? And you can say those things, we are preventing those things won't happen again. I'm so sorry it has happened to you. You can say that. Then from patient's point of view, it's completely different. So now I will tell the brief framework of the clinical error. See, when any clinical errors happen, the first thing is admit the error. You're not going to hide or anything. See, open and transparent. That's the key of the clinical governance. Be open and be transparent. You have to say, unfortunately, error has happened, and I will explain you this. See, the medication you are having, the antibiotic gentamicin, can cause side effects, and for that we need to check the blood levels, how much drug is in your blood, and then we adjust the dose. We did check, but unfortunately we missed to check the level at that time, or we missed to check the higher levels, and then we gave the same dose. So the gentamicin is higher in your blood level, and unfortunately you had a side effects due to that. So it's open, transparent, accept the error, accept the mistake, obviously with an apology. You can't say, oh, it's happened. No, it's not like that. So you need to say, I'm so sorry to say. And you also add, I sincerely apologize on behalf of the whole team that this has happened. Usually this shouldn't have happened. I'm so sorry to say that's happened. I apologize. And then a pause. Definitely patient will be reacting in terms of like anger and in terms of they're upset, and they will cause all those emotions, definitely, because anybody, we know that, and we can't say they shouldn't have all those things. It's a normal thing to expect all those emotions. Then you have to give some time, as the other Dr. Kinley said, in terms of you can't continue the conversation completely with answer all the questions when people are angry. You can just take a pause. That doesn't mean you are ignoring. Just take a pause and listen, and then you continuously apologize again and again. Then when people are in a state to listen, then you can tell explanation, these are the things that happened. So that's the first thing. Second thing is, mistake has happened, and what are we going to do in terms of support and rectification? That's the priority. The second priority is that, rather than investigation and action points, the second priority is what are we going to do for that particular patient. Let's say in this situation, stopping gentamicin, we have already stopped. That we have to tell. The gentamicin we stopped, and then no more errors and no more damage or harm to people. That's the first thing. And the next one is, yes, we need to send you urgently for the ENT specialist, which is like an ear, nose, throat specialist, and they will assess you and then check your all the other things in terms of hearing, whether it's okay as well. So usually hearing is not affected, but we need to check because we have done the mistake and already it's happened. So you are the priority and we need to take care of you. So this is in this scenario. Let's say in terms of others, then the immediate question will come. So what will happen to the infection? Then you can say, we have already spoken with the microbiology team who are experts in treating infection. So we will get an alternate similar efficacious antibiotic to check with you. So this is to reassure the patient. This is the priority number 2. The priority number 1 is admit the mistake, open, honest, transparent. Priority number 2 is how we are going to support the patient from side effects or any damage or harmful effects has happened. That's the second priority. Third priority is let them know that in terms of yes, you will still complain, and we can give the details about pulse and things to say yes, you can complain and we take that seriously. Then when you say we take that seriously, what do we do comes the fourth point. What do we do when you say seriously? What do you do with that? Then we can say there is a team of people with multidisciplinary team. The different people sit and discuss about. They will analyze. They will investigate what has happened, where did it go wrong, whether it's something wrong, and then they will analyze how we can rectify, whether to educate the person or it's an individual error or a system error. So no need to go in detail to the patient, but the examiner will ask you, what will you do, all these things. So with the patient, you can stop with that. So we are going to analyze and then investigate what went wrong, and we will rectify our mistakes wherever the situation is so that it won't happen again to anyone else in this situation. Then you can also say, I'm so sorry. From your point of view, it's already happened. I'm sincerely apologize to you. So this is what the steps is. Open, transparent, admit the mistakes, support the patient in terms of what we are doing for the effect or harmful effects had gone already. Then you can ask them in terms of, yes, I agree with you. It's very upsetting and I can see you angry. So you can make a complaint and there is the pulse team, so we take it seriously. Then we'll investigate the complaint, or even they didn't give a complaint. That's what it is here. So even if the patient says, for example, no, I don't want to complain, then you can say that's your choice, and that's so you can say that's so kind of you in terms of not giving complaint, and you're so kind of like a professionals, but we won't leave it like that. So just because you didn't complain, we don't close the case. We will still investigate and then look into it. What are the possibilities where we can rectify? Then that will reassure the patient. So this is how it is. From patient's point of view, they want to know what has happened. They want to know what you're going to do for me. They want to know, I'm not happy with what has happened. I want to make a complaint because I didn't think the NHS can do this, and they can make a complaint. So you direct them to which way they can complain. And the last thing is about what you're going to do. See, the other questions can come. Do you know who did the mistakes? Then you have to say, I don't know. The patient can ask, you're hiding, you're supporting a colleague, but whatever they say, we have to be patient and say, I'm so sorry, we don't know at this point. And they say, in the meeting, can I come? Because mostly or maximum, it's only professional meeting. People won't be allowed. So what will happen is they have a meeting and they produce the report or anything. Then one of the persons from that meeting can have a chat with the patient or the relative. But the person, let's say I did a mistake. I don't think I will be facing the patient or the relative by going it. Say I can do the reflection. The people who are doing the investigation will talk to me and then get my reflection, and they will pass on the information. See, I can say, for example, okay, I'm deeply sorry about the situation. I regret I shouldn't have done this. So I learned from my mistakes. So anything, I'll concentrate on the policies and things. Then they will say everything. Oh yes, I spoke with Dr. Ramesh. He has done the mistakes. He's realized the mistakes. He said he will be cautious in future so that he will avoid those mistakes. And they will pass on the message either in writing, or if the patient is willing to ask, we'll give the option in terms of talking to them face to face. So these are the questions they can ask. So that's how the whole scenario, the medical error or the medication error or any error should happen. Yeah.
Is there a possibility that the examiner might ask who all are there in the root cause analysis team? Will they go into this detail?
No need to explain, because you can say there is a team. Nobody knows, isn't it? So you can't say for example, like a medical. There will be a lead. There will be a lead like I don't want you to take it and then tell the examiner, but just for awareness, I'm telling you. See, there is something called the medical management team will be there in every hospital. The trust will be there, and the incident system is called DATEX in most of the trust. So there is a team who investigate. So there will be a team, let's say like a ward manager or like a ward sister in charge of the person and the pharmacist will be in the team. So everybody will be there. So no need to worry about who will be involved in it. If we say there is a team in terms of incident management and risk management team, they won't ask more into it. So no need to be depth in terms of who will be there. You can call them as a team, and they will take the incident. They'll take the, when I say, let's say for example, I report to a system called Datex, and then I'll report to the system, and it will go to the recipient will receive that. First of all, they'll receive, okay, I said something happened, and they will file the system, and they will analyze and investigate and speak to the person involved. Then they'll come to a conclusion, okay, yes, the mistakes have happened, and in that case we need to avoid all those things, and they will disseminate the information as well. It won't stop there. The clinical governance meeting that we discussed, and then it will be discussed in the departmental clinical governance meeting, and it will be discussed in the trust-wide clinical governance meeting, and there will be a report of that. So each and every medical errors or medication errors or anything will be reported, and there'll be an outcome. So it will be passed on to the entire trust. So that's how they work. Okay. So that's why I would suggest, see, all of you to bear that in mind. So know about the system, or particularly in this case, the scenario clearly, thoroughly, and then you start practicing. So I'm not saying don't practice at all, but always study from the background. Without knowing the knowledge and without knowing what to ask, it's very difficult to improve your role play sessions, because you need to know exactly what to ask, and then how do you ask. See, it's just like, for example, without knowing how to examine the heart and the lungs, how can you go and see the patient and say whether they have got a chest infection or not? You need to know how to pick up crackles or wheeze, and then the JVP, everything. Then only you can come to a conclusion what is what. So communication skill station is, first of all, knowledge, and then put the knowledge into practice in the way of communication. So without the knowledge, I don't think we can be an expert in communication. See, each and everything we have to tell, I don't know. That's not the best way of communication. So the basic knowledge is expected in each and every stations. I would say go hand in hand. So read about it, get the knowledge, and then start practicing. Only practice is not going to change anything. So at the end of 10 role play sessions, you will be at the same level unless you update everything. So I'm not telling about this scenario. Each and every scenario is like that. So when it is a breaking bad news, you need to know exactly what is the breaking bad news. What is the structure involved? What am I going to do? What are the key things I need to tell? And then only you can imply that in practice. Similar thing, confidentiality means exactly what is what. Let's say anything else, a breaking bad news, telling the like a taxi driver about the seizure activity and you need to stop driving, and telling the patient about HIV positive, you need to tell your wife about HIV status, and telling about the procedure, let's say ERCP to the person. Let's say you are explaining the procedure about the CAVG to a person. So you need to know exactly what is in there. So without knowing that, it's very difficult to jump in. And that's where I said, yes, role play is very important. Equally, you need to know the basic of that station and the basic knowledge of what is expected. And in any communication skills, it comes with emotions. It's not only the knowledge, it also comes with emotions. So you need to have a strategy how to deal with emotions. Let's say in this case, angry patient. When people raise their voice, we shouldn't raise their voice. At least we can lower down our voice. And I've told this many number of times before in my all free sessions. See, when people talk to you fast, you need to slow down your speech in terms of rate. When they talk fast, you can't talk fast in between. Let's say, for example, so do you think I have cancer? And you can't say yes. It's not like a race. You have to slow down and say. You can say yes, but you have to slow down and say. And again, when people opposite us will be raising their voice, you need to slow down. If they say, I'm not happy about it, and you would have done the mistakes, and you say, it's not me, it's somebody else. You can't say that. It's not an argument. We tend to do it. Normally, we tend to do it, but this is a profession. So we need to look after our professionalism. And then that's why the biggest clue is, if somebody talks fast, slow it down. Somebody raises their voice, slow down your voice. So that will come particularly in terms of angry situation where the patient or the surrogate is angry. You need to follow this. So these are the principles we need to know first. And then only we can put those things and practice. Then while putting in practice, we have some issues. We will have some issues because it's a habit. Because whatever we learned so far years together won't go away quite easily. So we do the same thing again and again. And now in terms of, just like, for example, a bit of feedback for Dr. Bilal today. See, he got the scenario wrong. That's completely different. I'm not going into that. So need to be careful about reading the scenario, getting the theory. But whatever he had done, so first thing itself, I have read the case notes and then you tell me what you're about is different. And then again, understand your concern. Again, see, that's again, there's, to me as a patient, it hasn't got any emotion, just a statement. That's all. I understand your concern. What you're trying to tell, I don't know. So then it's just like a statement. So you need to mingle with the patient, truly with the patient. So to me, it looks like, right, I'm so sorry to say, it looks like I'm always open and honest in terms of feedback. So it always looks like you're reading a news. Okay, I understand your concern. What do you tell me? So again, the voice should be down if you're immediately concerned. So even when I say reading the news, the best example of reading the news in terms of emotions. So if you look at all the news, you can say, they will say with chirpy voice and things, okay, cricket, T20 has done today and this particular team has won. So I'm not saying which team, I don't want any politics here. So they will say which team has won and that'll be chirpy voice. And then they'll say, okay, all over the country, the January New Year has been celebrated. But when they say something about somebody, if somebody died, or let's say some bad news, immediately the voice goes down. They won't be in that chirpy voice. They won't say that, they say the so-and-so died. They won't say that. They will immediately slow down the voice. So that's what it is. If you are going to ask about the really concerns or anything, you can't speak with the same voice. That itself tells for the other person that you are not speaking from your heart. You're just talking. It's a statement. It's not a true reflection of what we do. So that we need to take care of it. And then you say like it will be very stressful for you and things. It's very, very difficult because again, all those things, get into the situation and feel for it, really get into the situations and talk with emotions. It's not like a clear statement. And to do that, when you know the intensity of the situation in terms of emotions and outward effects, and that's what we call empathy. So we need to know how the other person would feel in this situation. If we know that, automatically the feel will come to us. If we don't know that, it's not going to happen. So that where we need to be trained in that. It's not only for below and for everyone. So empathy is a skill we need to learn. See, we do all the time in usual like a practice situations. Let's say, for example, you go somewhere out and you see somebody is going to fall. You immediately go and grab them. You don't think in terms of cognition, like what is the fall is due to. So which foot is getting in. And is the right foot or left foot? What angle? And what is the force? We don't think all of those things. So the thing is, you just go and grab immediately. So that preventing the fall. That is comes from emotions. There's no thinking. It's come from emotion. Exactly. Okay, the safety is important. It doesn't matter what the mechanism of fall. Even though we are very good in physics, we're not going to talk about it. So likewise here, you see somebody had suffered something. But I don't use the word suffered in PACES exam. I've told you for so many reasons. But for explanation, I'm telling you, somebody had some problems, effects, and then you need to feel for them. And then that effect is caused by us, our team. So we need to have that feeling. That's called empathy. And then you need to prepare our thinking. And those 5 minutes, you need to put ourselves into the box, into that feeling, and then only it will work. And that is what they are expecting in communication skill stations in everything. Every little thing. If they ask a question, there is a validity there. Then why they ask a question, what they are thinking, and we need to reassure them. So these are the things important. So in a nutshell, read the scenario properly, get the key points, get the theory, get a structure, write down the key points, what you're going to do, get into the emotions, have empathy. Yes, split the conversation into three. One, what we need to tell them. Two, what we need to get information from the patient or the surrogate. Three, how we are going to prepare with the examiner. In all the station 4 scenarios, we need to have this. Then it's a clear pause. And then, see, more than the pause, you will feel happy when you come out. You have done something great. That's a real consultation. That's a job satisfaction you have each and every time when we talk to the patient. Right. Any questions? Okay.
Final question.
Uh-huh.
In the medical error scenarios, is duty of candor the only legal issue? Is there any other legal issues here?
Yes, it is yes, that's the only legal issue. Duty of candor comes. Yeah.
Okay.
Because again, duty of candor is nothing but be open and transparent in terms of what we do for the treatment and care. That's the main thing. And again, explanation and putting people. See, another legal issue is, say, the incident report. We have to do it. See, once you know about an incident, it's all like a chain of things. It's not like two separate issues. Duty of candor is be open, transparent, tell whatever informed to the patient, and tell whatever happened to the organization as well. If we have done a mistake itself, we need to inform the concerned person to tell, like our seniors or managers, to say, okay, this has happened, and then we need to do an incident report to say what we learned from that. So it's all inclusive. So the being open, honest, transparent, that's a duty of candor. See, when we say duty, there's no choice. It's a duty, isn't it? When we say it's an optional, it's not optional. So that's the duty of candor.
Okay, thank you.
Okay, right. So for people who are coming to this session for the first time, see, there is a website, waytopaces.com, www.waytopaces.com, and I have lots of free videos under the section videos in there, lots of videos in the YouTube and lots of videos in Facebook as well. All like role plays and also case-based discussions and topic-based discussions, so that you can go through there. And we are in all the social media, for example, Instagram, Twitter, and Facebook, as just mentioned. And there's a YouTube channel, Way to Paces, as well. And we also have a WhatsApp group, Way to Paces. And if you want to join in the WhatsApp group, ping me. I will text my mobile number in the chat. Right, that's okay. So that's the end of the session. Thank you. See you soon. Bye-bye.
Thank you very much.
Way to Paces, the right way.